So I presented on this topic recently to Jay in Manchester. So apologies if some of you were at that meeting and you were at that presentation, but I don't think there's too much overlap between the two seminars. So I'm hoping for many of you this is a new topic. So before I jump into this, I'll just explain who I am. So my name is Michael Anderson. So I'm a GP. I work in New York. 1 day a week at the moment as a salary GP, and I'm also a health economist. So most of my research fits around these broad themes of healthcare quality finance, healthcare financing quality and incentives, and these are the key areas that I'm researching at the moment. So I'm particularly interested in who owns healthcare providers and what impact that has on the management and organisation and delivery of healthcare services. So I've done lots of work on private hospitals, and now I'm doing more work on corporate providers in general practice. I do quite a lot of work on workforce planning and strategy, more focused these days on primary care and skill mix changes in the primary care setting, and do a fair bit of work on low value care. So I evaluated the NHS England evidence-based interventions programme, and now with Evan Contapantelis, we have the PhD student Yuan Tian, which some of you may know, who's looking at low value care indicators in general practice under one of the jointly funded School of Primary Care Research and Patient Safety Transformation Centre's PhD projects. And I also do work on antimicrobial resistance, which is a very interesting cross-cutting issue with lots of across human, animal, and environmental health sectors, but also lots of cross-cutting implications in terms of healthcare provider ownership and who are the prescribers and low value care, a lot of linked to antimicrobial resistance. So this particular topic, clinical pharmacists in primary care, covers, well, I guess 3 of these things: workforce planning and strategy, low value care, and antimicrobial resistance. And I've always been quite interested in how clinical pharmacists are being used in general practice, because I've seen such varied applications. So right from the one of the practices I trained in, we would have a clinical pharmacist that was upskilled as an independent prescriber and was not just doing medication reviews, but actually seeing patients independently presenting with acute complaints. So this is a very upskilled independent practitioner. To other uses of clinical pharmacists where their role is predominantly on doing medication reviews and medicines management. And now what I'm seeing is I'm not necessarily working with a clinical pharmacist on a day-to-day. With the advent of ours, the Additional Roles Reimbursement Scheme, quite a lot of clinical pharmacists roles are being being outsourced to these private companies that are working across PCNs, and you purchase hours from clinical pharmacists. So it's just you don't necessarily have that face-to-face interaction. So I've seen the whole rationale for this started with, well, there's such variation in how the clinical pharmacists are being used. Can we exploit any of this to try to understand some of the implications for prescribing quality? And this was originally intended as a 2-stage exercise, and we wanted to look at ours and look at what's happening with clinical pharmacists. But it gets very messy after 2019 in terms of trying to attribute clinical pharmacist activity to individual general practices because of the PCNs. So we thought we would start with before 2019. So where it's a bit cleaner, where you can attribute clinical pharmacist activity to individual general practices. So I'll talk about that in a moment, but just a general overview here on what's happened with clinical pharmacists in general practice. So over the last decade and a half, there has been a big push centrally for greater use of clinical pharmacists in general practice. This started with the 5-year forward view. Then there was a clinical pharmacist in general practice pilot. So, I know this is work that Rachel has been involved in throughout from the beginning with Tony Avery in Nottingham. And, after positive findings from this general practice pilot, there was the general practice forward view, which committed to employing 1,500 clinical pharmacists to work in general practice over 5 years. And then, as I've mentioned, the additional roles reimbursement scheme came in 2019, which created funding for 26,000 additional roles in general practice. And the ambition was that we would have 6 clinical pharmacists for each PCN by 2024. So this is the bottom bit is can't see that number there. 6,500, yeah. So as of September 2023, there were 6,500 clinical pharmacists working in general practice. So there's been a massive expansion of clinical pharmacists in general practice. So from there are roughly around 35,000 GPs. So we're seeing, to give you a sense of scale. And there is at the moment about 6,500 general practices as well. So there's roughly now 1 clinical pharmacist per general practice. So what do we know from the existing evidence on this topic? So fortunately, there are some quite comprehensive literature reviews on this. So a literature review published in 2019 looked at the impact of integrating pharmacists into primary care teams, looked at 28 studies, and they found some evidence on reduced medication costs and hazardous prescribing, but there was mixed evidence from those studies. There's a more recent literature review published by an academic team based in Dublin, and they looked at integrating pharmacists within general practice to optimize prescribing for patients with polypharmacy. And there was quite strong evidence from 23 studies. So 10 of those 23 studies, 11 studies focused on potential inappropriate prescribing, and 10 of those showed reductions. But there was mixed economic impact, with many studies not actually necessarily looking at the economic impact. Now, from the UK, there is quite strong evidence based on the pincer intervention. So again, this is work that Rachel's been heavily involved in from the beginning. So there has been an RCT of a pharmacist-led IT intervention for medication errors that showed significant reductions, and an economic evaluation led by Rachel showed this was cost-effective with a mean ISA of around £4,000. So there has been an East Midlands rollout of the pincer intervention, which again, in this more recent study that I think Rachel and Tommy were involved in, showed reduction in hazardous prescribing over 6 and 12 months. There is, so Igor, my co-author on this paper, did publish a evaluation of the rollout of additional roles in general practice, but didn't focus specifically on pharmacists, but showed that the number of allied healthcare professionals was associated with a greater proportion of narrow spectrum antibiotic prescribing. So what did we want to do? So as I mentioned, this came from a discussion between Igor and myself when we were trying to brainstorm different ideas that we could collaborate on. And I talked about my experience with clinical pharmacists. He talked about his experience on this previous paper and about how they had looked at new roles, but they hadn't necessarily looked specifically at clinical pharmacists. Now, I mentioned that we had ambitions of looking at this post 2019. That's when I think it actually gets really interesting, because we have 1,500 clinical pharmacists up to then, but after there's been a wider expansion post 2019. But we decided to start with this pre-2019 time period, just because at that point clinical pharmacists were only directly employed by practices, so we could very clearly isolate where they were working and attribute their impact. Where it gets a bit complicated after then. So we use the NHS England primary care workforce data. We use practice list demographics from the Office of Health Improvement and Disparity. So I'll talk about the covariates that we used in a moment. And all of the prescribing data for the general practices is publicly available through the English prescribing data set. So you can get every medication that is dispensed from practices, well, prescribed and then dispensed from pharmacists from the English prescribing dataset. So which prescribing outcomes did we look at? So there isn't any consensus in the literature regarding what specific prescribing outcomes you should use in this setting. Looking at those previous systematic reviews, there was a very broad range of different prescribing outcomes that were used. We focused on the prescribing outcomes that were most commonly used in those existing reviews, and that was the total number of prescriptions, which is a good indicator of polypharmacy, the total cost of medicines, which is a good indicator of the efficiency of prescribing, the total number of antibiotic prescriptions, whether the share of broad spectrum versus narrow spectrum. So both of these are quite good at antibiotic stewardship indicators. We looked at opioid prescriptions and also an indicator of high dose opioid prescriptions, and also we looked at the average daily quantities of anxiolytics. So these are benzodiazepines. So these are good indicators of harmful prescribing. In terms of the practice level covariates that we use, so we used the age gender structure, we used the deprivation of the practice population, so that's the income component of the IMD at the LSOA level, and the practice population size. And we also looked at the workforce composition at the practice level, so the number of GPs, the number of nurses, the number of direct patient care staff, obviously excluding pharmacists. And we looked at whether the practice was dispensing or not dispensing, and whether they had a GMS, a PMS, or an APMS contract, which the GMS is the core contract. Those other contracts allow some, they're locally agreed contracts, which allow some additional services to be provided by the practices. So we defined our primary analysis used a treatment variable, a dummy variable, whether their practice had at least one clinical pharmacist active within that practice. And then we did a supplementary analysis where we split the number of pharmacists per 1,000 patients for each practice into tertiles. And this was to examine if there was any kind of dose response to the number of pharmacists that were employed in a practice proportional to the practice size. Now, we use a two-way fixed effects model. So this is not causal. We are looking at associations. So being completely transparent, the limitation to this is we don't fully take into account the fact that if a practice is, if it is a practice employing pharmacists, if they're inherently different to other practices, that is a unobserved practice characteristic that we can't take into account. So that is a flaw to this. So for that reason, we don't describe our findings as causal. We describe them as examining associations. And you'll see here that we have a dummy variable pharm, which is equal to 1 if a pharmacist is present in the practice at any one time. We use practice fixed effects and times fixed effects, and then X is the vector of time varying practice level covariates that I've just described. Now, if you look at our period of analysis, you'll see that from the beginning, so we start from September 2015 because there's a change in methodology for how they collect the workforce data. So most of these studies will only use data from that period, and there was only 3% of practices at that point had a clinical pharmacist. By the end of our study period, 20% of practices was employing a clinical pharmacist. So there's quite a significant expansion in terms of treated practices. If we compare some of the descriptives in practices that adopted clinical pharmacists versus non-adopters, we see that generally they're larger practices. So their mean practice list is around 10,000 versus 7,000. They have better staffing generally. So they have around 6 GP full-time equivalents versus 4 in the non-treated practices. They have higher numbers of nurses and other direct patient care staff. And there were only minor differences in patient list demographics. So if we look at our main analysis, where we just use that dummy treatment variable, whether the practice has just one clinical pharmacist, we see significant reductions in 3 of our 7 prescribing indicators, specifically the total cost of medicines, the total number of opioid prescriptions, and the average daily quantities of anxiolytics. But when we look at the tertile analysis, we find that these differences are primarily driven by the practices with the higher number of pharmacists. So this suggests that there may be something happening where there's very large practices that are employing only one clinical pharmacist or a part-time clinical pharmacist, where they're not necessarily having the same impact, and that there probably is a kind of critical mass of pharmacists that's required in a practice for some of these positive impacts to be seen at the practice level. But when we look at the highest tertile, where there's 0.16 pharmacists per 1,000 patients, we see significant impacts for opioid prescribing, anxiolytic prescribing, the total cost of medicines, the total number of antibiotic prescriptions, and the total number of prescriptions per 1,000 patients. So this is the first study that has done this using the practice level information, and we have shown that but we have to caveat this. Obviously, all of the work that Rachel has done with Tony Avery is individual patient level data, which is probably more robust it is more robust from a methodological perspective than looking at practice level information. But the advantage of this study is how comprehensive it is in terms of the coverage of England. So we're looking at all practices over this time period at a range of different prescribing outcomes, and we show that there is some signal that having clinical pharmacists in the practice does result in better quality prescribing, and it supports the hypothesis that clinical pharmacist implementation results in prescribing improvements. So we had some quite positive feedback on the paper when it was published. So it was in the top 10 most viewed articles in the BJGP last year. And the National Association of Clinical Pharmacists in General Practice, so they kind of picked it up on social media, and they were very positive about the findings of the review. So I've already talked about some of the strengths and weaknesses, but I'll emphasize again, this is practice level data, it's not individual patient level data. And also, one thing that we don't take into account is that there is lots of variation in the roles of clinical pharmacists at CCGs. So, like, I've worked in areas where there's lots of clinical pharmacists employed. Well, they're ICBs now, but at that time they were CCGs, and we would get regular prescribing audit reports. That doesn't seem to happen at my current practice anymore. This is when I was working in Walsall, and I do think that's another area that needs to be examined in terms of how clinical pharmacists are used at the commissioning level. Although, considering recent cuts to kind of ICB staffing, I'm not sure to what extent that still happens, to be honest. So we say that our findings support the ongoing national policy to expand clinical pharmacist implementation. But really, what I'd like to do is I want to evaluate what's happened since. And I talked about this in Che. I think there's probably scope to do a mixed methods evaluation of clinical pharmacist roles in ours. And arguably, it's probably more important that takes place because there's been more resources spent on clinical pharmacists in ours, and the number of clinical pharmacists in ours is much higher than those that are employed by general practices themselves. And also, there's such huge variation in their contracting models. There's lots of clinical pharmacists directly that are directly employed by the PCN that work in one or two practices, versus on the other end of the spectrum, what I've just mentioned, lots of private companies where clinical pharmacists work remotely and they kind of sell clinical pharmacist time on an hourly basis. And I do think the implications are very different for those contracting models, because I do think some of the benefits you get as a GP is building a relationship with your clinical pharmacist and getting to know who they are, and they'll help you with things and you'll help them with things. And it's kind of also, it allows them to correct you, I would say. It allows them to call you up more often on if you make a mistake, where I feel like that doesn't necessarily happen as much in this kind of more distant model where they're working remotely. and they're not working for the same organization or an affiliated organization through the PCN.